Good afternoon, good evening, good morning. My name is Simone Carter. I lead Integrated Outbreak Analytics for UNICEF's Public Health Emergencies team, and I manage the Social Sciences Analytics cell in the DRC. So today I'm just going to speak with you a little bit about understanding what is Integrated Outbreak Analytics, how this works, a little bit of history of the Social Sciences cell, some examples of how IOA has been implemented, how we get data used, and just a case study at the end of vaccine engagement. So what is the CASS? The Social Sciences Analytics Cell was set up in 2018 in the DRC as part of the Eastern DRC Ebola outbreak. So this was the first time that we had a platform of multi-actors, multi-disciplines working together to provide systematic evidence to inform outbreak response. So at the beginning, it was not a big team, one person. What I was doing was trying to support an understanding of outbreak dynamics. So why we might see more women affected in one area, greater delays in treatment seeking in another, and trying to help understand that to better inform outbreak response. In the beginning of 2019, we had a terms of reference signed off to exist as a unit next to the epidemiological cell to inform the outbreak, all of the different commissions, pillars, and response actors. In the second year of the outbreak, we received funds from Wellcome Trust and DFID, or FCDO, to model the CASS for future outbreaks. The approach was really quite positive, and so the government of the DRC, or the Ministry of Health, asked to replicate the same structure for COVID-19 and the 11th Ebola outbreak. At the same time, we supported at a global level by setting up what's called the analytics. Oops, sorry, my screen jumped. What's called the Analytics for Outbreaks working group, and this supports an integrated approach to outbreak analytics at a global level. So that's been ongoing since June 2020. We developed guidance from the best practices from Ebola for COVID, and have been working now for cholera, COVID, the plague, as well as reopened for the Ebola outbreak in Guinea in 2021. So we support globally as well as in country. So in the DRC, the Social Sciences Analytics Cell is really an operational team providing rapid studies, real-time evidence to inform decision-making strategies and interventions in epidemics, public health emergencies. We really aim not just about collecting data, but it's about really supporting the partners and getting data used. And we'll look a little bit about what is the co-development of evidence-based recommendations and how we really ensure that the evidence is used from a process of questions development and tool development to presentation of results. We really create space for an integrated outbreak analytics approach, which I'll go into a little bit later, and really working through local researchers, building partnerships through national institutions to make sure that this is something that is a skill set that is existent and strong in country. So what is Integrated Outbreak Analytics? So basically in 2019, there was a publication on outbreak analytics, and this talks about all the different new sexy ways in which we can use epidemiological data, surveillance data to estimate the likely impact of the outbreak, the number of cases, do all kinds of modeling, estimate the effectiveness of different control measures, etc. And this is fantastic and brilliant, and we have amazing data that comes out of that. But one of the things that we raised that was missing is if we can't understand why a particular group is affected more than another, or why we're seeing greater delays in treatment seeking or higher numbers of children, or if we don't understand those underlying factors and drivers of the outbreak, as well as the impacts of the outbreak on other community health dimensions, we're missing how to more effectively and efficiently respond to the outbreak. And so what we proposed was an integrated outbreaks approach, which really also looks at systems, structures, behaviors, access to services, and really all those different types of dimensions over time. Also understanding through qualitative evidence, kind of like case control, looking at why something is different in one community or one health zone versus another, ensuring that everything that we're doing, are we monitoring that against engagement and trust and response actors, and how we're really making sure that we do all of our humanitarian response work in a do no harm approach. So this is a kind of a full picture, but I will take you through it. So I'll give a couple of examples, and this is one of the different types of data sources that we look at to understand the impacts of COVID on communities and community health in the DRC. So in the DRC, testing for COVID is limited, but we are not looking at the epidemiological data in the form of the number of COVID cases or surveillance data in that way. But what we do use is DHS2, so health services use data. And we monitor that over time and to see if there's been changes. And so what we can see here is we look at that from 2018 using an interrupted time series model. And so we can see here specifically that there is a decrease in some health services use in Kinshasa at the onset of COVID. We would look at epidemiological trends in health outcomes. So for example, this graph here is analyzing data on sexual violence and access and use of family planning, but that might also be trends in malnutrition, in measles, and malaria, and other disease as well. We do qualitative monthly interviews with healthcare workers and community members to understand access, availability, barriers to services since COVID-19. But we might see, for example, that those barriers to services are related to socioeconomic factors. And so we also bring in data on the socioeconomic impacts of COVID-19. What are the prices of food, baskets, exchange rates, access to work, or impacts on income. And those data we bring in and we look at that as well to see, does that correlate with what we're seeing as potential reported reasons for what we see in decrease of health services. We also look, of course, at private healthcare facility data, which might not be included in the DHS2. We do healthcare worker surveys, or we bring in quantitative surveys from other actors at community level as well. Healthcare workers are an excellent resource of information, telling us about perceived risk, visits, impact on their services, their dynamics in communities, etc. And what you can see with the different logos around is, of course, this data isn't all from the CASS. The CASS creates a platform where we bring all this different data together, but we really work to inform the Ministry of Health COVID-19 response. Another example up here is from Ebola in 2018 to 20. So we understood that there was a higher number of children than expected under 5 infected with Ebola. But what we didn't understand is why necessarily that was happening. And so we brought together again multiple data sources. So when we conducted illness narratives and verbal autopsies with the parents and healthcare workers that had been in direct contact with child cases, what we saw in those qualitative, really long and detailed surveys was that parents were not delaying seeking care for children under 5, but that they were not recognizing symptoms. So they themselves said, they didn't understand the symptoms of their child. They didn't understand how their child could have been affected, but they did bring their child to a healthcare facility right away. At the healthcare facility, they reported stories of bed sharing, of ensuring that the child got an injection because they didn't think the child had Ebola, but they wanted the child to get an injection, believing that was the best form of medical care. Reporting that healthcare services were free, so that reinforced their willingness to seek care, etc. Then we looked at DHS2 data, so that's at the bottom left here. And what we saw was real increases where there was free healthcare in the services used for children under 5. With epidemiological data, we saw that children under 5 were very quick to go to healthcare facility. There was not a delay in treatment seeking. When we looked at some of the healthcare worker data, what we also saw was that healthcare workers themselves said that there had been overcrowding and high numbers of high numbers of patient visits, especially for children under 5. And when we looked at that impact of free healthcare, what we saw was, of course, if we're seeing increases of 200% and 300%, when we look at the IPC, the infection prevention reports, we looked at the healthcare facilities with the most nosocomial infections, so infections happening intra-hospital or healthcare facility, they were happening in facilities with less than 6 beds. So if you did a math calculation, what we would see is actually there was no way that there could have 1 person per bed with that number, with that percentage increase in health services use. We were also seeing that only 50% of healthcare facilities in these areas had actually been supported with infection prevention control materials as well. And finally, what we did was when we were able to get data on transmission chain analysis at the top left, what we were seeing is actually children were infecting children inside care facilities. And this was because we weren't identifying the symptoms. So they were being put in the same beds because there was overcrowding. The healthcare facilities were often not supported. People were not able to detect the symptoms. They were using perfusion or injections. And so all of these were factors which increased the risk and likelihood that a child would be infected. So this led to greater strategies in terms of identification of symptoms, understanding that children could be at risk, reinforcing healthcare facilities which were smaller sized to prevent transmission at a nosocomial level. Finally, this last one, we also look at the impacts of COVID-19 on women and girls specifically. Again, we have multiple data sources, household and healthcare worker surveys, the DHS2 data. We look at a chronology of events. So it's great to look at all of this, but if we don't understand it over time, what different events happened, were there border closures, were there increase in prices, were there reduced access to transport, different rules in place that impact impact work, impact socioeconomic status, impact access to a healthcare facility, etc., school closures. So all of this data has to be mapped over time for us to really understand data by events, and in context of pre-existing gender dynamics, conflict dynamics, and displacement. But all of the actors that you see here are the ones who contribute to the kinds of reports and data analysis that we do in an integrated way. And this way, everybody signs off together and everybody owns the data, and there's a better advocacy for the use of this evidence for action. So I'll take an example from kind of beginning to end in a little bit of a slower way on healthcare workers and nosocomial infection from the 2018-20 Ebola outbreak. So an example from North Kivu. We did healthcare worker surveys at a representative level, and what we found was in Health Zone B, so one of the health zones, there was the highest number of healthcare workers who reported feeling unable to talk to patients about Ebola, unable to detect a potential Ebola case, and feeling unable to protect themselves or their patients from infection. So this brings us to the question of saying, okay, so does that mean that there's actually an increased number of nosocomial infections? And so our second finding, looking at epi analysis, is what we found is actually, yes, that area in a particular time did have a higher rate of nosocomial infection at the same time where we were seeing these healthcare worker surveys conducted. So the question then was, well, what makes that difference? So we need to go back to the data and say, why is this happening? So when we looked at why through the healthcare worker surveys, actually what we found in Health Zone B, the majority of healthcare workers were reporting that they were receiving less training overall compared to other health zones. And also that when they received a healthcare support, they were getting that support outside of their structure. So I want to say, okay, but is this true? We need to triangulate that with program data. What we saw in program data was that actually only or less than 50% of the healthcare facilities were reporting having been supported, or sorry, that the IPC reports we're saying that only actually 50% of those had actually been supported. So of course that then did reconfirm what we were seeing in the healthcare worker surveys. So then we're saying, okay, so why is this happening? Why are they receiving less support? And that's where that timeline and geomap is really critical for us to ensure that we're understanding holistically what's happening. So we see that people are reporting feeling less able to stop infection. We're seeing increased rates of infection in that area. We're seeing that the potential reason is because they're not reporting getting support, or that they're getting support off-site. We see that seems to be the case, but during a particular time. And so what we did then is say, okay, well, what was happening in March 2019? And actually, this is a time where the healthcare facilities had been attacked in this area. And so that people were actually, IPC healthcare workers were less wanting to go to the facilities to provide training. Some of the areas were no longer accessible. So if we were giving training, it was off-site, but often some of them were not being able to be supported because we simply couldn't reach them because of the security situation at that time. So how can we turn these findings into action? Because all of this is great, but if we can't do something with it, then of course it's not why we want to collect data in an outbreak. So what we did is we presented this across the sub-coordination levels at that health zone level and that coordination level. We developed the infection prevention and WASH teams developed programs to reinforce support to the healthcare facilities, especially the smaller structures, aiming to cover 100% of healthcare facilities in that area, reinforcing the importance of providing training on site. And a lot of scale up was invested in practical and hands-on training to really address problems like how would you stop a nosocomial infection in your center. So on this, right, how does data get used? How do we really make sure that this is possible? So I'll just open up the whole slide here. So our research questions are a study question. It gets identified from an epidemiological situation, right? So number of cases, number of nosocomial infection, transmission in a new area, but it might also come from a commission or a pillar request. So the IPC teams might want to know why they have more nosocomial infection in one area, or healthcare facilities might want to know why there's a decrease or an increase of services used in another area. It might come from existing data. So like we saw in the healthcare worker survey, that we have one question, one answer, but it leaves us with another question that we need to understand. There might also be a change in context. So for example, right now we do studies in cholera in Eastern DRC, but there was a volcano that erupted. So we need to adapt our survey questions to understand how the impact of the volcano has increased or decreased potential risk or impacted potential risk of cholera in that area. So we develop a research question and terms of reference. Critical part of the terms of reference is making sure that we know how the results will be used. So if we cannot demonstrate a user of the results or ensuring that there's an audience and a willingness, including funds or flexibility of funds to act on evidence, we shouldn't be collecting the data. We want to make sure that that study is validated by the coordination or commission or the local health actors within 24 to 72 hours. With COVID, sometimes that takes a little bit longer. It might be 3 to 4 days or 3 to 5 days. We collect, analyze, and we develop presentations. During Ebola, this could take 2 to 5 days. Under COVID, this might take 2 to 3 weeks, depending on the size and the area of the data collection. Then we want to present the results. And presenting results cannot just be at coordination level. So it's really critical that we develop presentations that are adapted for the audience. So one study might result in 10 versions of a presentation, and everyone is digested a little bit differently for different audiences. So if we're working with the WASH or IPC commission versus working with the health actors or working with those working in gender or coordination level, we need to communicate the results in a way that is really useful. And so we really focus on developing multiple presentations that can be adapted and used and encourage and facilitate the co-development of recommendations. So we present to one group, and together with them, we co-develop recommendations with actors, timelines, and indicators. So this is something that they get to decide on, but we also will help them track that over time. And by showing that they're using evidence, they also can use that for additional funding, additional reports, et cetera. We make sure that they have that access to them. When we present the results to other actors, we show them how previous presentations had also developed action. So this kind of snowball effect of encouraging the use of evidence. We develop one final presentation that has all of the co-development recommendations in it. And we put all of that into a tool called the Manito. And the Manito is an Excel tool, it's online, but it helps us to track the recommendations by study, by location, by indicator over time, and by actor who's responsible, or by commission or cluster who's going to follow that up. We also, so our primary aim is real-time data. So we are looking at PowerPoints, drafts, anything we can do. We do bulletins, we do anything we can. But one of the feedback we got in the last year, especially with COVID and the impacts of COVID, was a request to have more structured briefs. So what you're seeing on the board here. The reason being is that then the different actors who contribute, so we have lots of different NGOs and civil society actors who contribute their program data to these analyses. And what that means is they can use that as well for funding requests, advocacy purposes. So we did develop these with them. We use a Congolese local designer who then helps us do this, who gets the projects, who gets involved. And then these get used by all kinds of civil society actors as well. They're published always first in French and then made available in English. And so the Manito, this is kind of what our Manito tracking looks like. So as said, it's an Excel tool. The database is online, it's open access. It allows us to track recommendations by the study. Was it a survey? Was it integrated, qualitative, quantitative? By the disease type as well. So what disease was a study related to, the location, the specific actor or commission or cluster who is responsible for following up that recommendation. As an example, in the 2018-2020 Ebola outbreak, we did 55 different operational analyses or mini studies, and we co-developed 111 recommendations that by the end of the outbreak had been taken into consideration. But then when we had the 2021 Ebola resurgence, there was a very quick thing of going, we need to study what's happening, what could be refusal. And we said, hold on a second. We have 111 recommendations. We have done 55 studies in that area. We don't need more data. What we need to do is use evidence that is already existing. And so we reviewed all of the pre-existing studies and the co-developed recommendations, and we held a kind of virtual workshop to identify 22 key priority must-do recommendations to support the response with response actors. Of those, actually, they ended up putting on 58 different actions related to those 22 different recommendations across the commissions based on pre-existing evidence. So it's just kind of a highlight that we don't actually always need to be conducting studies. I think we have been, especially in a time of COVID, become absolutely data obsessed. We think we need to collect a lot more than we do when there's so much data that does exist, and we can just use that, but we need to be ready to put down our egos, stop wanting to do new research, get what's out there, and help teams at a field location digest it in a way that is actionable and in real time. And I think sometimes we're not willing. We send reports and we spend long documents, and nobody has the time to read that. And so that's when it gets lost. But by being available and having the tool already there and doing the time and taking the time, to meet with the teams in the evening to identify the use of evidence that they could easily follow up, made this possible. So it reduced the burden on communities in terms of new data collection, and it reinforced the accountability and use of evidence in a new outbreak. So when we think about getting data used, there's some real kind of key importance. So we had, as mentioned at the beginning, we had Wellcome Trust and the University of Oxford do a modeling of what made the CASS work, what made it successful, and how we got all this data used. One of it is really making sure that we are inclusive in the study design. So are we including the commissions, the EPI and health data analysis, basically the users of evidence? Are we making sure they're included in the survey design and the study questions? You don't want to finish collecting data and have people say, you didn't use a methodology that is right for us. We don't have the right denominator. We don't have the right detail we need, or you didn't ask this and this question. So really making sure that they are involved in that process. Checking that we know how they're going to use data. Is there money available? Is there flexibility? Do we know who and how this data can be used? Making sure that we triangulate data. There's so much data out there. There's so many studies, especially in the COVID-19 context. And we need to not be scared to say, actually, we don't need to collect this and this and this piece of data because we can use other data, and this is good enough to act on. I think we've become very, very obsessed with collecting new data when there's excellent sources of data available. And that comes into as well data coordination of, are we bringing together all the different data sources and reflecting on how they can be used and how we can support each other in better using. So really setting up mechanisms for the use of evidence, whether that's systematic presentation of results, so clusters, commissions, Ministry of Health, leadership, being ready to make multiple presentations. We present at civil society, we present at midwife associations, we present at local health actors, local NGOs, digesting data in a way that is useful for them to take action as well. We also organize discussions and briefings with influencers and decision makers. So making sure that we have the ear of donor working groups as well as Ministry of Health. And that we are triangulating and bringing our data together with real experts. So we get support from Harvard Humanitarian Initiative, from London School, from Antwerp Tropical Medicine, really to review some of our tools and methodologies or the way we present evidence to make sure that it is really presented in a way that is strong and good enough. So one last kind of example, this is something that's been close to my heart recently, is social sciences. We've become in COVID this thing that's presenting a lot of big data, a lot of perception surveys, and something that is very concerning for me recently is this talk of vaccine hesitancy. And so what we want to kind of highlight here is how an integrated outbreak analytics approach is really important in questions like vaccine engagement and uptake, or the hesitancy potentially. So what we did, I mean, we get asked a lot, okay, well, what were the lessons learned from Ebola, and how can we reinforce community engagement and vaccines? So we did a meta-synthesis of all of the CASS data from the 10th and 11th Ebola outbreak, so over 7,500 households in surveys, sorry. And we kind of summarized the key findings. So when we looked at misunderstanding and misinformation, number one was on side effects and the eligibility and strategy. So why certain people were getting vaccine and other people were not, what was ring vaccination and how that really worked. And there was a lot of misunderstanding about that. There was misunderstanding on why you would get sick after the vaccine. There was distrust because people did not understand how it worked. There was no communication material actually saying, this is how the vaccine works. When a vaccine injects your body, this is what an antibody works. However, when we asked people, did you know about polio? And can you explain to me how polio works? It was incredible how well people knew those things. So what we were lacking was a clear comparison to, these are side effects from vaccines like all the other vaccines, and this is how vaccines work. But we weren't doing that. We were operating in a very vertical way and not providing the detailed requested information. We promoted a vaccine, but then we didn't ensure that it was available for everyone. So again, thinking about the eligibility criteria, we were using unknown healthcare workers when we were administering the vaccine. We were providing the vaccine on unknown locations or unusual locations, tents, anywhere outside of a routine healthcare facility. There was presence of police at some vaccination locations. We were using forms that were not available in local language. There was a perception that the healthcare workers who typically were giving polio and other vaccines were not able to respond to the questions that were most important to communities, like how the vaccine worked, what the eligibility criteria was, how come some people were getting it or not, what were the side effects. And so kind of an example is this poster on the side that just says, accept the vaccine to stop Ebola. And this doesn't give any of the requested information. In addition, it promotes something that we were actually not offering to everybody. So it implies that with the vaccine, you can stop Ebola, but then we're not giving it to everybody. So does that then mean we don't really want to stop Ebola? So when we think about perception surveys in a COVID-19 context, we tend to ask this thing of going, would you accept the vaccine? So we're seeing these big perception surveys all over saying, 60% of the population would or wouldn't accept the vaccine. And that's missing some very critical information. So there's no contextualization. We're not looking at what are the policies in place. Is the vaccine available for everybody? Are people able to access it? Is there border closures, lack of transport, limited movement, curfews, all of which might affect your access to work, and then your access to finance, and then your access to transport to a vaccine. But they also might influence your perception of a vaccine if the government has not signed off on particular vaccines. Your access to the vaccine or the vaccine locations and the cost of transport to get there, your access to information or misinformation. It's difficult to understand the cause of acceptance if you're only asking somebody, would you accept the vaccine? We don't know if it's a trust issue, a financial issue, a concern about symptoms, or if you don't believe that you're eligible because you are under 55 and it's AstraZeneca. There's many things that we wouldn't understand in terms of causes of a particular behavior or reported behavior. The other thing is, it's about a perceived action, right? So we are giving a hypothetical situation. This is not actual behavior. So we often think that if somebody said something, that's exactly what they will do. Lots of people know smoking is bad for you, however, they're still smoking. So, you know, information doesn't equal behavior, and reported potential behavior doesn't equal actual behavior. There's a lack of nuances at community level. So we've been seeing reports lately that, you know, women are more hesitant than men, but is that because women have different access to information? Is that because we have presented COVID as a largely male disease? Is it because that they do not believe that they're eligible? So again, we're not getting into those nuances. And by reporting on vaccine hesitancy or perceived or reported hesitancy, there's nothing we can do about that. We would just consider the only response would then to say to people, accept the vaccine, because we haven't gone into understanding what it is that is required to build trust or be willingness in engaging in the vaccine. And which leaves us with, very similar to Ebola, again, posters that say, accept the vaccine to protect myself, not recognizing whether there's enough vaccines in country for even the whole population, whether people have enough information, whether they have transport to even, if they can even afford transport to get a measles vaccine for their child right now as a result of the socioeconomic impacts. And so all of these other factors, and all we say is accept the vaccine. So by promoting this kind of using social sciences evidence to talk about vaccine hesitancy in this way can really be dangerous. We create an image and a perception of communities as either defiant or hesitant based on a hypothetical question. We're not looking at any of the factors which influence the behavior or engagement, and we cannot develop appropriate action. So thinking about what is an integrated outbreak analytics approach to analyzing vaccine engagement. First, we need to look at epidemiological data. So we know that my proximity to a disease will influence my engagement with prevention and protective behavior. So as an example, we are more likely to participate in cancer or diabetes walks and preventive behavior when we have somebody who has been affected by cancer or diabetes. And so proximity to a disease, as in the number of cases in my area or the physical proximity, the caseload, but also the case fatality, that kind of epi data around a disease influences our engagement with prevention behavior. If it doesn't happen commonly in my neighborhood or my area or my country, or if I believe that, or I have received information that there is very little death related to that disease, especially compared to other diseases in my neighborhood, which might be measles, malnutrition, malaria, that epi data will influence my engagement with preventive behavior, sorry. Health services data. So again, am I accessing routine services normally? Has COVID-19 and the socioeconomic impacts of COVID-19 already reduced my access to routine services? So am I already being limited by socioeconomic factors to access postnatal care, prenatal care, malnutrition care, other vaccines? And if that's been influenced, would I really spend the first little bit of money I have to go get myself a vaccine versus take my child for malnutrition services, for example? Community and individual perceptions and behaviors. So what is my perceived risk? What is my access to information? What are my behaviors for other things? So again, what are the socioeconomic factors which influence my behavior? What are the curfews which influence my behavior? Or which, because of curfews, I have to stay overnight at work because I cannot transport at night when I finish work. And this limits my time at home with my family. And so going to get a vaccine, which takes 3 hours, might just not be possible. What are healthcare worker services provision? Is there availability of vaccines? Is the healthcare workers able to provide them? Are they able to provide information about them? What are their perceived risks and impacts on other vaccine services? Then again, looking at things of like events and timelines. So what were the policies in terms of vaccine? What were the political restrictions? What is the access to information and response strategies? And this we need to think about outside of country as well. So when France and the Netherlands and other countries say we will not provide AstraZeneca for people under 55, and the US doesn't provide AstraZeneca at all, how would that influence then the government of DRC in trying to encourage their population to accept a vaccine, which has been widely discouraged in other countries? How has it been influenced when borders have been closed, when market prices have gone up, when people haven't been able to move? So there's lots of factors at a local, national, and international level in terms of information which reaches communities and events which reach communities, which would influence engagement. I mentioned several times the aspects of movements, prices, and all of this recognizing that we're looking at context of particular conflict, gender, culture, other factors which affect communities. In the cholera study that we do in Eastern DRC, we repeatedly ask, what is your primary health concern or concerning your community? And it's actually never cholera. It's almost rarely health. It's most often displacement or conflict or money or food. So really recognizing what are community real priorities and engaging with those before we talk about hesitancy for a vaccine potentially. So when you think about what drives vaccine uptake, and this is just some examples here in the DRC, we know that to have motivation to engage in a vaccine, we need to talk about what people think and feel. And thinking and feeling doesn't just come from myself. Again, it comes from trust in who do I trust the most for information. So I trust my government leadership. I might trust the French leadership because I have an aunt who's living in France. And so I might think and feel particular ways. When I read that there's actually less than 1% of the population of the DRC that would have access to a vaccine compared to much higher percentages in other countries, does that make me feel like, well, how come in my country we don't even have enough to cover? So do they really want us to uptake the vaccine or to take on the vaccine? When my president says, actually, other countries are not using AstraZeneca, so I think our country should have another one. How will that influence my vaccine engagement? And again, recognizing that in other countries, maybe that's a very positive, they're saying the same thing. In fact, they're not even allowing their countries to have it. So how will that make me feel about a vaccine that's being offered to me as a woman who's under 55? There's other social processes. So what are the vaccine norms in my communities? Are we already engaging with other vaccines? Do we have access to them? Do I have the transport and ability to move? Do I have the cost, the financial aspects to move? When I go to a healthcare facility, do the healthcare workers, are they able to answer the questions that I have? So those things might influence my motivation. But then even if I was motivated, there are very practical issues which may influence. So the vaccine that was provided in the DRC had an expiry of 4 months. So is there even enough vaccines between my first and second dose if I didn't go in the first few months to get my first dose? I might be affected by the socioeconomic impacts, which means I cannot afford transport, or the transport that I can afford, I prefer to spend on taking my child to get his vaccines. Understanding really the factors that really would influence my vaccine uptake, and looking at that more holistically, and what is my other engagement and access to other healthcare services, and what is being argued by my government, and is my government arguing similar things to other governments as well? And so all of these things will influence. And so by not presenting data that is holistic, by not presenting really based on EPI, based on all the other things, what we're doing is really painting an incoherent, using social science as evidence to paint an incoherent and incomplete and unethical picture of actually communities' willingness and engagement with vaccines. So we have a couple of recommendations for an integrated outbreak analytics approach. So really making sure that we're mixing qualitative and quantitative data. We are able to explain causes of behavior, perceptions, or engagement. We're asking those kinds of questions. We're understanding and analyzing and presenting data against context. So caseload, case fatality, information available, government policies in country, and global government policies, which may vary or influence those in my country. What different events have taken place as well. Asking action-oriented questions. So what information do you need, from who and how? What factors would influence your uptake? And those are things that we can then more easily action. Ensuring that the key data users are involved in the study. So are we including the people who are making policies, decisions, communication campaigns? Are they being involved in the study design, and are they willing to use the data when we collect it? So this is just a great example on the top right of the PARC Resolve to Save Lives, to show the different events across the EPI curve over time. So making sure as well that we continue to monitor routine vaccination uptake and data. So making sure that we're seeing those different impacts over time beyond just COVID, not looking at something in a vertical way. Repeating surveys over time, are we seeing a change? So did we use evidence, inform a change? Did we mark that change on a curve in terms of vaccine engagement, and then monitor any changes afterwards? Making sure that we really do present results across the commissions, the clusters, the different actors, that we're supporting their use of communicating on the key questions, on the key issues. So do we communicate on how vaccine works, who gets it, how it's eligible, all of that kind of very critical information. And co-developing actions. So tracking what we are agreeing on doing over time and by actor, and seeing if that influences. So just a little plug, we have, as mentioned, a global working group. We support multiple countries for multiple diseases, the plague, cholera, Ebola, COVID-19, and other healthcare related or health systems, services, public health emergencies at a global and country level. Everything we do is available online. So there's a Google Drive, there's a web page. We are shifting everything slowly onto the GOARN Knowledge Hub as well. But please don't hesitate to get in touch if you'd like to access any of the tools, documents, examples. It's all available online. Thanks very much for the time, and have a good afternoon.